Right, so we're recording now. I'm using a different textbook, so I'll give you the information via email, okay, on heart blocks. Okay, remember last week when we said share?
The heart blocks is for the final, right?
Yes. Okay,
Okay.
so heart block. Remember this is the SA node, and here is your AV node. Hello. Hello.
Can hear you now.
Okay.
Now we can hear you.
I can hear you now.
Okay. All right. Do you see my whiteboard or no?
Yes.
Okay. All right. So I
Yes.
was saying. So what do you call that delay again when the SA node after the SA node fires the electrical impulse?
PR interval.
Before.
PR interval.
Okay, very good. So there's a PR interval which is lasting between 0.12 to 0.2
To
seconds, right?
0.
Before
Yeah.
the same electrical impulse is passed down to the ventricles. So we got that part. Now, heart blocks, there are 3 degrees of heart blocks. These are variations. So, first degree heart block would be simply a delay. So first degree, the only thing wrong here is there is a prolonged PR interval. So the PR interval here is 0.2 seconds, meaning longer than 0.2 seconds. However, the patient typically doesn't have any symptoms because it's not consistent. Plus, it's not really that big of a deal. What I'm trying to say is the patient won't exhibit any symptoms, and otherwise the rhythm would be normal. Okay, so obviously here, if you measure the PR interval here, this is more than one big block. The maximum length of a normal PR interval should only be 0.2 seconds, right? So
Yes.
this one obviously is, so this is the PR interval for this one. So this is already one big block here. So this is 1.8 big blocks. Okay, so it's quite long. The heart rate naturally drops a little bit. So if this one, if we count a 6-second strip, let's try here. 1, 2, 3, 4, 5. 1 second. 1, 2, 3, 4, 5. 2 seconds. 1, 2, 3, 4, 5. 3 seconds. So let's say this is our 3-second marker here. And looks like this is a 6-second strip. Okay, so the heart rate here is still close to 60. You see that? So the heart rate pretty much is at 60 or maybe slightly below 60, maybe 50, 56, 50, anywhere between 56 and 60, right? So the patient typically does not need any intervention here. And if you look at the treatment, does it say any treatment? Thank you for reading, Ashley.
A treatment is not typically required for first degree AV block unless the patient is having symptoms, which is very rare. If the patient is symptomatic, then the underlying causes are treated to alleviate symptoms.
Okay, and what are listed as causes here? So we have varying causes. Typically, it's a usually a side effect of your beta blockers or even from digoxin. Okay, remember we talked about prodysrhythmia last week. What does prodysrhythmia mean again?
They induce arrhythmias, more
Okay,
arrhythmias.
right. So the way antidysrhythmics work is, unfortunately, they interrupt the normal, or rather the existing rhythm. So therefore, inadvertently, they may cause other dysrhythmias as a result. So let's go to second degree now. Second degree has two types. There is second degree AV block type 1, and there's also second degree block AV block type 2. It's called Mobitz 1 and Mobitz 2. In type 1, this is type 1. So the PR interval is normal. However, it becomes longer and longer. Typically, it runs in three. So after the third one, the patient loses a QRS, meaning one QRS is dropped. Okay, so the patient symptom, they may say, oh, I felt like my heart skipped a beat, because it really did. It skipped a beat, but type 1 typically is not very serious. However, if the patient has symptoms, let's say the blood pressure is already low, or they have dizziness, lightheadedness, shortness of breath, then the treatment is atropine 0.5. That typically gets the heartbeat going faster. Um, However, in second degree type 2, there is there's consistency in the PR interval, meaning it doesn't get any longer. However, how many QRSs are dropped now? Is it the same? This is type 1. Then you have type 2 here. Is it the same?
No.
No, not at all. So you have here, you have less QRSs here, meaning you have more QRSs dropped now. So the way I remembered heart blocks from school is, my teacher put it in terms of a relationship. So let's say me and Magda are going out. In first degree heart block, when me and Magda go on a date, I arrive late. Okay, but we're still on. You understand? Hello?
Yeah.
Yes.
Yes.
So if you
Yes.
go back here in the illustration, there is simply a delay in the impulse, but at least the impulse, the SA node, still gets to the AV node. It's just late. Okay, it's just delayed. So just like in our relationship between me and Magda, in first degree heart block, all that's happening is I'm arriving late, but I still show up. So in terms of the SA node impulses, they get to the AV node, they just arrive there late. Okay, that's it for first degree. In second degree type 1, I arrive later and later. So with every date we set, one time I'm an hour late, the next date I'm 2 hours late, and then on the third date I'm 3 hours late. And then finally, on the fourth date, I stood her up. I stand her up every now and then. Does that help?
Yeah.
Okay. In type 2, second degree type 2, I'm not getting later and later, but I'm standing up Magda more and more now. Okay, this is how I always remembered the heart blocks from especially the second degree, because there's two types. Okay, I don't know if that makes sense. So in second degree type 1, if the patient, this is first degree heart block. In second degree type 1, I arrive later and later each time, and then I stand her up. So meaning here, the SA node signal gets to the AV node later and later and later, and then finally one of the SA node impulses is blocked, meaning, but we don't know what's blocking it. We just don't know that one of the signals every now and then, every few beats, doesn't get to the AV node. Something is blocking it from getting there. So that's second degree type 1. If the patient has symptoms, then we treat it with atropine. Second degree type 2, because although the PR interval remains consistent, however, more than one QRSs are now being missed. So if you look at the heartbeat here, what is the ventricular rate? Can you estimate the
That's
ventricular rate?
30, 30.
Okay,
30.
in the 30s. So can somebody live with a 30, with their heart rate in the 30s?
No.
Ventricular rate? No. So will this patient have symptoms?
Yes.
Yeah.
Yes.
Definitely symptomatic. So the patient will now require treatment, obviously. And it is also dangerous because this is a potentially life-threatening dysrhythmia, because this can lead to the worst type of heart block, which is now a complete heart block, which we'll discuss shortly. So in second degree type 2, this patient, of course, will receive atropine, as with second degree type 1. However, atropine won't be enough here. The patient will have to be put on a temporary pacemaker, an external pacemaker, if you still remember from last week. So this is a transcutaneous pacemaker until the patient receives a permanent one. A third degree heart block is the worst. So here's an example. Do you guys have your paper calipers? Okay, everybody take out your paper calipers and then measure this R to this R, and then see if it's about the same occurrence as from this R to this R, and also likewise from this R to this R. Are they regular?
No.
No, they are not regular.
Well, don't be so strict. In mine,
The last one isn't.
well, the last one,
The last one is irregular.
yeah, just slightly, right? But you can see from the first R to R and the second R to R and almost the third R to R, are they pretty much regularly occurring?
Yes.
Yes.
Yeah.
And then do the same for the P waves. The P waves are here. This is a P wave. This is a P wave. This is a P wave, P wave, P wave, P wave. So if you measure the P waves, are they occurring regularly?
No.
Actually, they are.
How?
Yeah, I'm measuring them. They're regular.
Yes.
Yeah, the P waves are regular.
Yeah, they're occurring regularly. So I have a regularly occurring P wave and also a regularly occurring R wave, QRS complexes. So remember I said at the beginning of last week that the AV node is also a pacemaker?
Yeah.
You're right. And
Yeah.
what is the intrinsic rate of the SA node? How many impulses can it generate?
60 to 100.
60 to
And
100.
right, and how many impulses can the AV node generate?
20 to
40
40.
to 60. 40 to
40.
60.
40 to
40
60.
to
40 to
60.
60.
Okay, so this is the proof that there is a complete heart block, meaning there is a complete AV disassociation, meaning the SA node and the AV node are not talking to each other. The SA node is firing as evidenced by the SA node is firing as evidenced by the presence of the P waves. And look at the QRSs. They're also firing because you see the AV node is also firing because the QRSs are normal, right? But they have two completely different rates. You have a different atrial rate, which is between 60 to 100 if you count that. And there's also a different ventricular rate, which is obviously in the 40s. Okay, so something is blocking the impulses from the SA node from getting to the AV node. As a result, you have two different rates. You have a different atrial rate, you have a different ventricular rate. Of course, this will result, the most important contraction is always from the ventricles, correct? So what will happen to the patient's cardiac output here?
Well, decrease.
Decrease.
All right, can this patient survive on this situation?
No.
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 So a
No.
complete heart block must be treated with a pacemaker. So the same, of course, we can't put a permanent pacemaker right away. So the same thing, the patient will have to receive atropine and then a temporary pacemaker until we can insert a permanent pacemaker. And that's it for heart blocks. Any questions?
The question is, you mentioned it won't be on the exam, but you gave us this information for our,
This
what
will
do you
be
call
on the
that?
final.
It's going to be on the final, but not on the third exam. Okay.
No.
Okay. I got you.
Okay, so
Thank
again,
you.
there is a complete heart block here since the AV node is not getting the impulses from the SA node. That's why it's generating its own, but at a much lower rate because it can't generate 60. The AV node can only generate anywhere between 40 and 60 beats. You understand?
Yeah.
Okay, all right, so let's go now to shock. All right, shock is a perfusion concept, and we know perfusion is oxygenation, right? So this is something to do with oxygen delivery to the tissues. And again, as I discussed with you guys, for those who had 104 with me, this is the concept of perfusion. In order for perfusion to be possible, the pump must be working very well. there must be adequate blood volume, there must be vessels that can adjust their diameter, namely dilate and constrict in addition in response to the patient's changing oxygenation or perfusion needs. Okay, so if these are the three components of perfusion, these are also the same three causes of shock. Can somebody read the definition of shock?
Shock is white gas exchange with oxygenation and tissue perfusion needs are not met sufficiently to maintain cell function.
Very good. And take note that shock is a syndrome. So is shock a primary disease?
No.
No. Okay, so something else leads to shock. Okay, so shock, you can say it is a syndrome, and typically it's a condition rather than a disease. Stated here, it's a whole body response. Now, the signs and symptoms really are signs and symptoms of compensation, because if you remember in chapter 11, what will be triggered if the blood pressure drops or oxygen level drops? What response will automatically be triggered in your body? And
The sympathetic or something?
very good. So there will automatically be a sympathetic response, and that response will result in the signs and symptoms. Hello. Okay, so that the sympathetic response will result in the signs and symptoms that will be shown in shock. Okay, so there are 4 categories of shock. We have the hypovolemic, we have cardiogenic, we have obstructive shock, and then we have distributive shock. So there are 4. Hypovolemic shock falls under a volume problem. So if you look at our 3 elements here, so hypovolemic shock falls under here. So this is a loss of volume. Whereas cardiogenic shock is direct pump failure. This is different from indirect pump failure here, which is under obstructive shock. So this is indirect pump failure. So the difference between the two, if you look at the causes, look at the causes of cardiogenic shock. It's MI, cardiac arrest, dysrhythmias, namely VTAC, pulseless VTAC, or even VTAC with a pulse, or worse is VFib, or cardiomyopathies mentioned in chapter 35. Look at the causes in obstructive shock. Are these directly resulting from heart failure?
No.
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 That's why this falls under indirect, because this one, cardiogenic shock, the causes lead to heart failure. Okay, any of these will cause direct heart failure. Meaning here, as stated here, there is no
Yeah.
problem with blood volume. Okay, so let's say number 1 example we use here is an MI. So you go into a heart attack. This is chapter 38. So you have acute coronary syndrome. So there's loss of blood flow to one or more coronary arteries. As a result, there is myocardial injury, and then the pump fails directly, and then that will lead to shock. So the cause of death really after a heart attack is not the heart attack. The death is directly from cardiogenic shock. In obstructive shock, the heart here, in these conditions listed here, cardiac tamponade down to tension pneumothorax, did the pump fail directly?
No.
No.
Exactly.
Something outside or around the heart mechanically caused it to fail, or mechanically prevented the heart from functioning properly. As a result, though, the heart still failed, but not directly. It failed indirectly. So, for instance, let's use tension pneumothorax. We just finished this 2 weeks ago, right?
Mhm.
Yeah, okay.
Yeah.
So, in tension pneumothorax, you recall um, there is positive pressure. Let's say Al-Haji got shot. So Al-Haji got shot, and then there's a hole not only in his chest wall but also on his lung. So with each breath, air is escaping from Al-Haji's lung, and it had nowhere to go. So it's accumulating, and then caused the tracheal deviation, if you remember, right? And then the patient, Al-Haji eventually had really compromised hemodynamic numbers. So and then he went into obstructive shock. Uh, see the difference between the cardiogenic and obstructive?
Yeah.
Okay, another example is the PE. So the type of PE we'll use is the massive one. You remember the signs and symptoms or the effects of a massive PE? Was there um, hemodynamic instability?
Yes.
Yes.
Yeah, right. There was right ventricular dysfunction, right? The patient went into shock. So I mentioned 2 weeks ago that that was an example of an obstructive shock, meaning just indirect pump failure. The heart still failed, but not as a direct cause of the heart itself pumping. It's something around the heart or outside the heart that caused it to fail, preventing it from doing its job or from functioning properly. Lastly, so this one would be, of course, where will we put this in our um, so if hypovolemic shock falls under blood volume, where will you put cardiogenic and obstructive shock?
Huh?
Under pump
Pump.
failure.
Cardiogenic would be pump, and
Yeah.
then
Uh-huh. Right. So we have cardiogenic, which is direct pump failure. Then we have obstructive shock, which is indirect pump failure. And lastly, we have the distributive shock. So there are three types that fall under this category. One is sepsis. We have septic shock. The second is neurogenic shock, which is from spinal cord injury. And then the third is anaphylactic shock. We'll discuss each one after our break. So this is a vessel problem. So we have sepsis or septic shock. Then we have anaphylactic. Then we have neurogenic. So we will be going to different chapters here because chapter 37 will only address hypovolemic and septic shock. Anaphylactic will be in chapter 20. Neurogenic, I think, is 42 or 43, I'm not sure. And then, of course, cardiogenic is chapter 38, which Dr. Kudia already discussed with you, but I'll visit it again. Any questions so far about the concept? Because,
No.
all right, so what we'll do is, since we have the concept of perfusion, so since these three are the problems, these are the same three elements that we will have to address or manipulate in order to improve perfusion. For example, if the pump fails, can it handle regular blood volume?
No.
So what will we do to the blood volume in order to help the failing heart?
Well, if it's a loss of volume, you would increase it. You would.
Well, the question was for cardiogenic shock first. So we know that blood volume refers to preload, and the blood vessels refers to afterload from chapter 33. What will you do to the preload when your pump is in failure?
Would you decrease it?
You decrease the preload.
Very good. What will you do to the afterload?
You increase that.
I'm sorry,
Increase resistance.
Increase.
which one is it? Increase or decrease?
You increase the afterload.
Well, increasing afterload means you're going to constrict the blood vessel. So is it easy?
Resistance is
Hard.
increased.
Is it easy or hard to pump blood through very narrow blood vessels?
It'll be hard.
Oh, it's hard.
So what do we do to the afterload? Do we increase it or decrease it?
So
So we decrease it.
All right. So you see the principle? Is it any different from treating heart failure?
No.
Not at
really.
all. It's exactly the same because really, a patient in cardiogenic shock, are they in heart failure?
they are.
100% absolutely they are in heart failure. So it will be easy. You already know the concept. The management of cardiogenic shock is exactly what you learned in chapter 38, what you learned in chapter 35. Understood? Any question?
No.
All right, so we'll come back at 6:55. We'll take a 14-minute break.
Okay.
Thank you.